I want to help people feel well, feel healthy, and prevent disease processes and, in the end, death as long as possible for them to be as healthy as possible to be able to care for their families. So whenever I was a young girl, my mom, at one point, she was in a house fire and was burned. And after we had to spend so much time at the hospital, I just knew for some reason it felt normal to be there, which was very strange as a 15-year-old child to be like, hey, the hospital seems normal. This is where I want to be. And there was one nurse, and I actually remember her name. The lady was just extremely kind and caring and compassionate with my mom. And so, when I was thinking, what do I want to be when I grow up? I just constantly went back to that feeling of it felt normal in the hospital and it felt right and where I needed to be. And I had always cared for my mom, my little brother, and just my family in general. And so whenever I decided about what career path I wanted, I knew it was medicine. I first thought it would be a doctor, honestly. And that was just because honestly, I came from not any money and I knew that being a doctor, I would have money. And, but then, like I said, the lady that I was really, really inspired by was a nurse. And so that's what I actually ended up looking into was nursing. And so that's why I was like, well, I feel drawn to this. And I went to school to be a CNA, to see if I actually did like it in the hospital, like working there, not just being there and being around it. And did that for the first 2 years and was just like, yeah, this is where I'm supposed to be. I'm supposed to care for people. And so then I went back to school to be an RN. Probably the thing that surprised me early on, honestly, is the burnout. And that was very early. Like I would ask people because, I was inspired and I was young and I thought, hey, everybody loves this job. And I would ask people like, hey, what made you decide to be a nurse in clinicals during RN school? And their responses blew me away because they would say things like, well, I needed the money. Well, I have to take care of my family. And I was like, oh, well, okay, and because we were told all the way through school, if you're doing this for money, you're not doing it for a reason that is going to work because there's not that much money in it. And so we were like ingrained. That was just told to us all the time. And then to get out and that be people's answer, I was like, oh gosh. And then I did know that it was because of the things that were happening in the hospital. We were understaffed, we were short staffed, we had people who didn't know what they were getting themselves into. I was in charge on a very, very busy surgical medical floor 6 weeks after graduation as an RN. And so I had 7 patients and was in charge of these other nurses. They all had way more experience than me. But it was one of those things that the money, and I say it like that because they would throw bonuses that were just crazy at you, but that caused the burnout because then we were there 5, 6, 12-hour shifts a week. And we were like, okay, we have nothing left to give. And so I think that was the most surprising part to me was the amount of burnout, the amount of pure exhaustion and the fear, because I know walking out that first year or two of being an RN, I literally prayed leaving. God, please don't let me have done anything that causes anyone harm today. I have literally tried my best, and don't let there be anything that I didn't see or I didn't recognize that could be harmful to someone. And so then the thing that, really resonated was I like, and I like it. I like the puzzle of it. I love to solve what's going on. And I love to be able to see people later. And when I was in the hospital at first, it was day after day on the floor. And then it was in the ER. I did that for 10 years and it was, we made them feel better and sent them home, or we made sure that they were on the floor somewhere being treated. And so we never really got to see the end of that puzzle. And so that's kind of why I thought that primary care might be a better spot for me once I decided I wanted to do nurse practitioner instead of in the hospital for acute care. So I think a lot of it was we would have really sick people on these areas, and even in the ER, that really needed a lot more help and time, and we just didn't have it to give. And then on the opposite spectrum, you would have the people that were not near ill enough, let us say, for the ER. And they were there and they were very angry at the fact that they were not in a room and being cared for. But most of the time, there's one physician or one provider and multiple nurses. But that doesn't mean that that provider can get in to see you in a timely fashion if there's only one of them. And even one very sick person can mean the other 15 rooms just stop. Everything stops because there's only one person to make the higher decisions or the decisions of what are we going to do? Do they get discharged? Do they go to the floor? Who calls the accepting physicians if that provider's busy? And so it's a tension of, I need to give this time to these people, but I don't have the time, capacity, staff, anything to do that. And so when you're in the acute care setting, it's what's the sickest? How do we get them treated? And how do we get the other people home to their families without them being upset in the idea of we didn't find anything, so we didn't do anything? Because that's often what I would hear. You didn't do anything in the ER for people. We did. We ruled out sicknesses that meant they were dying today. And then we sent them home to follow up with their primary care. So when I went from that acute care setting and I was like, how do I make this better? How do I do this differently? I was like, with that, I thought that primary care would be better because you get to get a relationship. You get to know them, know their family, know their situation, know their social issues. So it helps to understand what's going on in their life and what is happening in their families. If they've lost a job, the stress that goes along with that. So I thought that would make that better. What I find often is the difference in the way I like to practice and the way that traditional healthcare says is I'm only supposed to spend like 5 to 7 minutes in that room with that patient. I can't get to know them. I can't get to know what's going on. I'm going to miss something. I mean, and that's evident every day that meds are missed, things are missed in traditional healthcare. Someone may forget to tell you something. So if you can't go over their history once you're in the room with them, something's missed. And so, heck, you're saying, hey, you need to do this, this, and this. And they're like, but I don't have a gallbladder. And you're like, oh, I didn't have that in my history. So it's very important for us to get a thorough history. And having a 5-minute visit, that's not possible. There is no way. I can ask you a lot of questions in 5 minutes, but I can't get a lot of answers, honestly, because we can't go through all of that. And so it's very hard, and I know people talk about the doctors or the providers who have their hand on the door. That is not a them wanting to get out of there. That's a them knowing that they're on a time restraint and they have people just like you that are in the room that they have to get to because they have to be able to do all of this in an 8-hour period or a 9-hour period, whatever their day is. And they have to make the bills. And doing that means it has to be quick. And it's not fair to you as a patient. It's not fair to me as a provider. And so that's why I don't want to practice that way. I hate that type of practice. And that is literally addressing what the sick care model is. And that's not what I want. I want to help people feel well, feel healthy, and prevent disease processes. And in the end, death, as long as possible for them to be as healthy as possible to be able to care for their families. So I think I was about a year into being a nurse practitioner and working through COVID and working in urgent care. When you come from the ER, urgent care is usually where you get hired as a nurse practitioner because they know you know sick and they know you know not sick. And so that's what they want because they want to make sure you can send people out or you can get them to the ER. And so when I became a nurse practitioner, started in urgent care, we were seeing a lot of patients, probably around 100 a day, 110, between 1 to 2 of us. And in some aspects, like 60 to 70 with one provider in the clinics. And that's a 12-hour period. You don't get lunch, you don't close, and you have to see people up until the minute the doors lock. So they walk in at 7:57, you're seeing them. It doesn't matter. So with that, it was such a struggle because I knew my staff that I worked with every day needed breaks. I knew that we were all overwhelmed. I knew that everybody was watching that door, like, please don't let anybody else walk in here at this time. And in the mornings, we all got there and it was a rush, like, let's hurry up and let's get this all started. And so there was no time. There was just no time was the biggest thing. And then when I would see patients, they would say, do you have a place you practice on your own? And I was like, nah, this is it. This is all I'm doing right now. And so after about a year of that, like even my family was like, what is wrong? And I was like, I don't know. Like I'm crying on the way to work. I am dreading work. Like this was my dream and I'm crying about it every day. So it was very, very eye-opening. And honestly, my husband is a huge push for me. And he was like, you could do this on your own because I just didn't know. Like I was applying at different primary care places and they were offering lower wages than my RN wages were. And now I have all this extra debt. And I'm like, what do I do? And my husband was like, you could do this on your own. And I was like, oh, well, I don't think I can. And he was like, you can. I know you can. And so we kind of got to talking and looking at things. And at first, I went and shadowed a nurse practitioner who has her own clinic, but only does direct primary care. And I was like, oh, what is this? This is something different. I don't know anything about this. And so whenever I shadowed her, I was like, this is really neat. Like you work by yourself, you don't have a whole lot of staff, but you spend time with your patients and they get the care they need. There is some limitations because, of course, if they don't have insurance, then you have to get a little creative on how you're going to practice and treat them and know what to do to send them to other places, to specialists, to get imaging, things like that. But that again is part of a puzzle. So I'm kind of a puzzle person. And so whenever I followed her around, I was like, this is how I want to practice. This is what I want to do. And my husband was a little concerned because he was like, well, how does that work? Because if you don't have enough patients, and who's giving you patients and that sort of thing. And so he did talk me into doing a hybrid clinic where I did take some insurances. I was very picky at the time, probably not as picky as I should have been, but I was picky at which insurances I took and why. But in the end, when I opened it as a hybrid, it worked for a while because then, some of the insurance companies, they put you in your in-network. And so they say, okay, we'll send you patients. And some people do actually look on their insurance website and see who in the area is their providers, their in-network. But for the most part, I came with 0 patients. And so it really has been just word of mouth. And with all of that, when I'm doing the hybrid, it's a little hard because I know how I want to practice. I want to spend time with these patients. I want to be in the room for longer. I want them to be able to reach out to me when they need something after hours. And I have a few thousand patients now. I can't do that with insurance patients and with direct primary care patients now. And that's kind of been the struggle is now I'm like, well, I feel like I'm getting back to what I didn't want to do. I don't want to be in there for 5 seconds, 5 minutes, whatever. And so now I'm at a pool of I'm practicing the way I want to, but I don't have enough time with the patients if I am seeing more insurance patients. And so that's been where I've struggled recently, is because I want to spend the time with them, and I want to be able to help them. And insurance says what you can and can't do. So again, your hands are tied whenever insurance says we're not paying for that, or you can't do that, or you can't see them for that. And that's where I feel like it's very hard, because if they're paying you a small amount of money, that has been a contract between you and the insurance company, your patients say, "Why can't I?" And you say, "It's not my choice." I agree. That is appropriate medicine. That is an appropriate treatment, but your insurance won't pay for that. So unless you're willing to pay for it yourself, whether that's direct primary care, cash pay in the pharmacy to get your medicine, imaging, any of that, then my hands are tied. I can't do that. I can't help you in that area. So that's where I think the struggle comes in, when you see that there is a way to do it without the insurance being so handcuffing. Um, and you're like, hey, there's a different way to do this, but getting everyone's buy-in, because everyone's been taught insurance is the way, that it's so hard to shift a mindset. And it is a entire mindset for an entire country to say, we're not doing this anymore. And that's really where I think us being advocates for our patients, because that's what we're taught, comes in very strong. Is you have to let them know it's not us. We are not the reason they can't get what they want. We are really, truly handcuffed by their insurance companies' rules and regulations when it comes to taking their insurance. If we don't take it, we're not handcuffed by anything. And so that's where I think the autonomy of having my own clinic and wanting to practice the way I want to practice is so heavy on me. It's so what I want to do. And I feel like I'm screaming it from the rooftops, but I feel like nobody hears you when you're screaming from the rooftop, even though you're trying to get the word out. So last year, I worked really hard with a few other nurse practitioners to help Oklahoma get our full practice authority as nurse practitioners. And we finally got that passed. It has been years in the making, but we finally did get that passed. So truly, my goal was to become autonomous in every which way, which starts with not having a supervising physician over you if you are able to practice independent, but also then to not have anyone tell you how you have to practice. And that means that I have to shift to no insurance. And I have to shift to where my patients are the most important thing, not what handcuffs I've been handcuffed by: regulations, rules, insurances, other entities such as, supervising physicians, or having to have, medical directors, things like that. And so that is my ultimate goal, is to be fully and truly autonomous. And that means I can't accept insurance, because I have to be able to treat patients the way they want to be treated. And of course, the way my schooling, my knowledge, my training, all the extra classes and training that I've done teaches me to treat them. Of course, that's not saying do any crazy things that I don't feel are appropriate or anything like that, but making sure that if it is safe and it does align with what is going on with that patient, and I feel that that is what is needed, it's done. It's not something that I have to go through an insurance company and do a prior authorization 400 times to get one medication approved or one procedure approved. Like, I don't really understand why there's a prior authorization to send someone to a specialist. Okay, if you're the one paying for the money, or for the medication, okay, fine. You get to say if they get that medicine, if that's the way our healthcare system works. But if I say a child who's had 4 ear infections in the last 3 months, and we've treated it appropriately every time, if I say, hey, they need to see an ENT doctor, I don't really understand why I have to go through more paces than just sending them a referral. And it's going to take weeks to get this prior authorization approved through an insurance company. And this child is just getting more and more ear infections, which means possible hearing loss, ruptured eardrums, scarring for their life in their eardrums. And I don't really, that's not appropriate. That is not appropriate care. And it's very hard as a provider who just wants to take care of someone to watch it happen like this and watch what that shows. So yes, my focus is primarily going to be getting away from any and all ways that we are handcuffed as providers to take care of our patients, and the relationship be between the patient and us as a provider. So if you feel tired, if you're having trouble sleeping, if you don't feel motivated to do the things you used to do, like breezing through the day, and you're like, I am so exhausted. I don't understand why I'm so fatigued. I don't know why I'm constantly feeling like I'm getting sicker. I don't know why I've had 4 upper respiratory infections this winter, and I don't normally have that. Or you're just overall not building muscle when you're trying to work out. You're not able to perform the way that you're used to performing. Things that used to feel like it was easy to do is no longer easy. You can't do that load of laundry in the evening time when you used to be fine with doing that and doing the dishes. It's kind of one of those things that's when we want to see you. We want to look at you, look at your labs, see what is going on, and see if we can help you get to feeling better. And that doesn't always happen in every realm. And that is where we want to come in alongside you and help you feel the best that you can feel. Feel like you used to. Feel like you, because that is the problem, is we are walking through this life not feeling like us anymore. And I want to help you feel the best I can help you feel. So if you want to get in touch with us and see if it's a good fit, if our clinic is a good fit, if you are a good fit for us, then you can always go either online to our website at www.thehometownprimarycare, or you can give us a call or a text message to 405-591-3584. We are there to answer questions. Of course, if it is something medical, we can't really answer that over the phone. So it's much better to do either an in-person or telemedicine consultation. We offer those all the Monday through Friday, 8 to 5, every day of the week. Or if you're like, hey, I'm ready to sign up, we have links on our website for you to sign up for direct primary care, weight loss, or for hormone replacement therapy. And all of those are just there on our website, or you can call our office and talk to our staff to find out if you're a right candidate, and have a consultation with me.